My, my name is Leo Riella. I'm the medical director of the Kidney Transplant Program at Mass General, and it is my pleasure to introduce our panelists today. We have Dr. Camille Nelson Cotton, who is the clinical director of the Transplant and Immune-Compromised Post-Infectious Disease Group at Mass General. She's also a leader nationally in the COVID-19 response in immune-suppressed patients. We also have, as a panelist here, Dr. Nahel Elias, who is the surgical director of the Kidney Transplant Program at Mass General, and also chair of the Quality Improvement Initiative in Transplantation. And this is going to be an interactive session. We have received many questions from the audience, and we try to incorporate that into the short talk that will come after me. And we hope to be able to answer the main questions that you may have in your background, and also learn about everything that we have discovered and understand now about COVID-19 in transplant patients. And without further delay, I'll get Dr. Cotton to get started to talk about the COVID-19. Thank you.
Great. Thanks so much, Leo. It's really a pleasure to be here today and to see so many names of people I've known over the years. It's really nice to see everybody, at least virtually. So I'm going to talk about COVID-19, including highlights on disease and then vaccination. Whoops, sorry. So the current trend, and this is from today, you can see that, we've had several peaks in the US. We've just come through yet another peak, as you can see here. Unfortunately, our numbers in Massachusetts are still sort of relatively high, and nationally, they're actually not continuing to fall, but rather creep up a bit in the past couple of weeks. So we had been getting better, and it remains to be seen what happens, especially with Thanksgiving and the other winter holidays coming up, where there's potential for increased exposure. Let's see. Don't seem to be advancing. There we go. There have been a lot of variants, but now what we are seeing, as you can see in orange across the United States, is really what we call the Delta variant. And that has taken over many months ago, really. So this is really all about Delta at this point. Basically, this is a virus that's more fit than other strains, and that's why it's really taken over and really increased the amount of disease that we've seen throughout the world. What about hospital admissions? Again, you can see that we still have a good number of hospital admissions, and this is even after we started vaccinating people. We started vaccines sort of here in the middle of the screen. Many of these hospitalizations are really from people who were not vaccinated, but we're still having significant rates of vaccination. Fortunately, when we have made a lot of improvements in management of COVID-19 in transplant patients. And interestingly, in the first half of last year with the pandemic, we saw a higher mortality rate, unfortunately, in transplant patients, but we really improved things from the first half of last year to the second half of last year. And this was actually data that we contributed to from a national program run from the University of Washington. So overall, with vaccines and better management, we really are doing a better job than we were. I just want to highlight, there were some questions about testing. And, the very best testing is the one that is the most sensitive, is when you get it in the back of the nose. The one that's the most uncomfortable is actually kind of the gold standard test. The testing that is in the front of the nose, but both of these are still what we call PCR testing, or the one that takes like 1 to 3 days to return. The one that's in the front of the nose is about 5 to 10% less sensitive or less detecting than the one in the back of the nose, but it's still pretty good. The rapid tests have issues both with false positives and false negatives. And in general, I don't recommend relying on the rapid tests because of the false positives and false negatives, which can really be problematic. I wanted to emphasize that although people are nervous about vaccines and effectiveness, by far and large, the highest risk situation is for people who are unvaccinated. So unvaccinated at all is really different than fully vaccinated. Unvaccinated people are 6 times more likely to test positive for virus, and as of recently are 11 to 12 times more likely to die from COVID-19. So vaccine really, really works. These vaccines are really a medical miracle, and we would not be where we are today without the vaccines. We are seeing some breakthrough cases. This will continue to happen. Overall, people are a lot less sick when they have breakthrough cases. And it does look like there's still significant transmission with breakthrough cases, although perhaps less than if they had natural disease. I wanted to show you this slide from the state of Massachusetts, which is, you hear about these breakthrough cases and you sort of worry, but if you look at the overall number of cases in green, that has continued to climb from July all the way through October. So the numbers have been sort of steadily going up over time, which is, it's a pandemic, we have ongoing disease. But then if you look at the hospitalizations in red and the deaths in blue, they're still very, very low. So even though we've had over 4 million, almost 5 million people vaccinated, about 1% have had a breakthrough case, which is low. That's like a vaccine efficacy of 99%, which is amazing. And you can see that a very small number of breakthrough cases have resulted in hospitalization or death. So that's vaccines work, and that message should be loud and clear. I wanted to touch on there are a lot of questions about vaccines. I wanted to just touch on the regulatory process, which is that the FDA reviews and approves vaccines. And then the Center for Disease Control Advisory Committee on Immunization Practice makes recommendations for how to implement the vaccines. So the FDA approves something, but doesn't say how to use it. And the CDC panel, of which I'm one of the 15 voting members, we make recommendations for how the vaccines should be used. And then there's a lot of confusion about what is a booster dose? What is an additional dose? What is a third dose? What does all that mean? And so for transplant patients, for mRNA vaccines, we wanted to really consider a primary vaccine series to be a total of 3 doses, because transplant patients didn't do as well with 2 doses. So it turns out they need 3. So that's why we call it an additional dose, but not a booster. Now, for many people that developed strong immune responses after 2 doses, not transplant patients in general, and then 6 months later, we are recommending a booster dose because boosters boost when somebody already had a strong response. So it's a little confusing, especially because now we are actually recommending that transplant patients get this 3rd dose and then 6 months later get a booster dose. So total of 4 doses. You probably all heard this in August. The Center for Disease Control recommended that moderate to severely immunocompromised people receive an additional dose, and that includes organ transplant patients. Okay, and I know that many of you went out and got the vaccine in August or shortly thereafter. And I would certainly hope that for those of you that haven't yet gotten a 3rd dose of mRNA vaccine, that you go and get that vaccine. I personally worked really hard on this recommendation and spent much of early August petitioning many groups nationally and working to change this policy. So from the 3 of us, Dr. Riella, Dr. Elias, and myself, we strongly encourage you to get that additional dose. There's been a lot of questions about why don't we check antibodies after vaccination? So right now, this is not recommended by the CDC. And so we at MGB are not recommending antibody testing. Dr. Riella has actually done lovely work with COVID-19 vaccines, looking at vaccine protection. And he and many others have shown that vaccine protection is actually a combination of antibody development and a cellular immune response. And if you just look at the antibodies, you can't really know what someone's immune response is. So it's really kind of a not very good or mediocre answer. And somebody might have a positive result or a negative result, but because we don't have information on the cellular immune response, and we also don't know what the threshold is, like at what point people are really protected. So it's actually sort of dangerous to know those results, because people might act and think that they're protected when they're not really protected, and vice versa. So we really don't recommend antibody testing, nor can we interpret those results for you. Nobody really can. So now we have an update where are people eligible for a booster shot? And this doesn't really apply to transplant patients, in that most transplant patients should have had a third dose. It does apply to transplant patients who got J&J initially, the Johnson & Johnson vaccine at least 2 months ago. And I thought that this would be good to put up, and I wanted to emphasize this because many of you probably have family members or people you live close to or spend a lot of time with. And many of them would actually be eligible for booster shots now. So I wanted to make sure you knew about this additional recommendation that just came out in October. And I'm going to talk a little bit more about that as well. So on the CDC panel, we recommended that certain groups should get a booster dose for sure. And that's people over the age of 65 for sure, people over the age of 18 who live in long-term care settings, and then people over the age of 50 with certain medical conditions. And I'll show you that list in just a minute. And then for people at somewhat lower risk, we said that they may receive the vaccine, and that's people under the age of 50 with certain medical conditions, or people aged 18 to 64 who are increased risk for exposure and transmission because of either what the work they do or where they live. And that any vaccine could be given as a booster: Pfizer, Moderna, or Johnson & Johnson, also called Janssen vaccine. And for people that got J&J, if they're at least 2 months out, and this is new for transplant patients and everybody else who got J&J, they should get a booster dose of vaccine, any of the 3 vaccines, at least 2 months after receiving their J&J vaccine. And this was a brief update when they looked at 9 different states, and unvaccinated people, the question is, can prior infection protect you? And the bottom line is not enough. And we definitely are seeing repeat infections. Unvaccinated people with a prior infection were 5 times more likely to have another positive COVID test compared to vaccinated people. So disease alone is not as protective as the vaccine. And so definitely get vaccinated as soon as possible. This is a list. This is a heck of a long list, even for us doctors in the field. But these are, anybody who has any of these things on this list who are over the age of 50 should get a booster. And anyone who has at least one of the things on this list under the age of 50 may get a booster. So that's a lot of Americans, especially even if you look at like BMI of 25 or greater. That's a lot of people. And then on November 2nd, we also made the recommendation to vaccinate children ages 5 to 11 with the Pfizer vaccine. The Pfizer vaccine is over 90% effective at preventing COVID in children aged 5 to 11. And this vaccine is really critical to preventing infections and possible severe disease. We are not giving children more than 2 doses, and no boosters are recommended at this point. Some say, oh, I don't want to bother, or I don't want my child to get that vaccine. The vaccines have been shown to be very safe. And what's been really concerning to me is you can see this increase in disease activity in the past couple of months with hospitalization rates among children aged 5 to 11 increasing. So this is a really good time to consider vaccination of children, grandchildren, family members. And I will tell you that on the CDC committee I'm on, all the members recommended vaccine for their children, their grandchildren, our family members. And in the infectious disease group at Massachusetts General Hospital, my fellow doctors, we are all vaccinating our children. So I hope that helps with decision making. I'm hearing a lot of people being hesitant about giving the vaccine, but we really feel that they are safe and effective. What about new treatments? So there's been a lot of fanfare about the 2 new treatments coming out. There's a Merck drug, which decreased the risk of hospitalization or death by about 50%. This has been approved in England, but not yet in the United States. And then there's a new Pfizer drug that resulted in an 89% reduction in risk of hospitalization or death. So looking even better than the Merck drug. Just to highlight that the Pfizer drug is a combination pill, and it's given with an HIV medication called ritonavir to keep drug levels high. And so there are some drug interactions with transplant medicines. So if you were to need this treatment, we would have to adjust your transplant medicines accordingly, but we do that all the time. So if you're at Mass General, you'd be fine. If you were in a faraway community hospital, you might want to highlight to them this issue. So far, we don't have information on how effective these new treatments will be in transplant patients, although we would anticipate that they would work pretty well. But so far, we just don't know. And I just want to close with saying that even though we have these vaccines and boosters and additional doses and all of that, we are not done. We all still need to mask when we are out in public. We need to wash our hands. We need to practice social distancing. We need to be careful with the number of people we socialize with. I'm doing all these things. I want to stay healthy and strong so that I can continue to go to work and take care of all of you. And I think we all need to continue to be cautious, especially with the numbers still being significantly increased in New England and throughout the country. Thanks a lot for your attention. I'm going to turn this over to Dr. Elias, and then we'll have a question and answer session at the end. Thanks.
Thank you very much, Camille. Thank you for a great presentation and for your work on the vaccines and your work with the CDC. So my name is Nahil Elias. As Leo mentioned, I'm the surgical director of the kidney transplant program, but also the quality chair, the quality improvement chair for the transplant center. And I'm going to talk a little bit about how does this affect the regulatory aspects and the requirements in transplantation. So many of you know that we in transplantation are truly the victims of our own success. The transplant is the standard of care for many organ failure types, and it is the best and only therapy for some of them. Now, we are limited, and unfortunately, compared to other surgeons who would recommend treatment for a patient and will take the patient to the operating room, I cannot do that for all my patients. We have a lot more patients on the waiting list, and this is the national data shown in here, and in red is the number of patients on the waiting list. And you see that number is close to over 110,000 patients currently. And down here are the number of living donors, deceased donors, and altogether how many total donors. And obviously, deceased donors will provide more than one organ. So we result in actually, we're just shy of 40,000 transplants per year as of last year. So compared to the 100,000 patients waiting, we don't have enough organs. So we are limited by the scarcity of the organs. And over the years, this has been recognized going back to 1984 when Congress passed the National Organ Transplant Act, which outlawed organ sales, created the Organ Procurement and Transplantation Network, which is the oversight agency over all transplant programs in the country. This is a division of the Department of Health and Human Services. Now, why is that important? That is important because they essentially regulate how we do our work and assure that we're doing the right things for our patients. And we want to do that throughout the country. And over the years, HHS passed the final rule on organ allocation. And what they recommended is that organ allocation should be based on sound medical judgment, shall seek to achieve the best use of donated organs, and shall be designed to avoid wasting organs, avoid futile transplants, and promote patient access to transplant. So we want to help the patients, but at the same time, we want to make sure that the organs are used in the right way when we don't have enough organs. So that's a big part of what we do day in and day out, in essence, evaluating the risk and benefit, which for a surgeon is very routine of our care. As a surgeon, every time we take a patient to the operating room, we compare their risk of the operation to their benefit of the operation. You know, as I tell people, surgery by definition is cutting somebody open to help them with a procedure, and there is hurt involved to help. So if I'm going to hurt the patient more than I'm going to help them, it is not worth proceeding with an operation. Now, in transplant, that is more significant of a piece, because in addition to the usual risk of the operation, there are other risks that are related to the donor. Do we get any, how good is the organ we're transplanting? Is there something related to the donor's history or their risk of carrying an infection or cancer? We also have significant risk in the recipient. And again, having an infection in a recipient or having cancer in the recipient makes them not ideal candidate at that time. So our role is really to modify the risk. You know, every time we do a transplant, the patient is benefiting, but the risk is modifiable, and we can decrease patients' risk by preparing them appropriately for the transplant. And this is where one of the pieces that are also important is the immunosuppression risk. As you all know, every time we perform an organ transplant, the patient's immune system will recognize the organ as a foreign organ, and that it will try to reject it. And this is where the patients will need immunosuppression. Unfortunately, that increases the risk of infection. And that's where infectious disease specialists like Dr. Cotton are always involved in caring for our patients to treat infections. And that's part of what we assess them for and prepare them for the transplant by decreasing their infectious risk as much as possible. And COVID is one of those infections that we have to deal with. And early on in the pandemic, we've realized that COVID is going to create a big challenge for abdominal organ transplant and all organ transplant for that matter. You know, looking at a big piece, and I know there were a few questions about, are we using organ donors who are COVID positive? And there's a lot of concern about transmitting COVID, especially early on in the pandemic. There were cases, especially lung recipients who received lungs from somebody who were COVID positive, who was not identified, and unfortunately the recipient did not do well and died from COVID. Even the surgeon who performed the operation had trouble with COVID. So I mean, that's where the risk we look into. Now, over the time of the pandemic, as we got better at taking care of the patients and identify COVID, there are some experiences, primarily using donors who had COVID and recovered from COVID, but then donated mostly months later. And Camille and our team, we published the first report of a live donor, actually, a woman who donated a kidney to her husband after she recovered from COVID. We actually waited a few months for her to recover and then did the transplant. Now, as far as using deceased donor who had COVID and died of something else, there are some early experiences that we're seeing, and we're still debating and assessing, have they recovered to the point that COVID may be in their nose, but it's not in their system and in their organs, and there is some concern about that. So we're not at a point that we're using organs from donors who died, and definitely not from those who died sick with COVID. But if they had COVID and recovered, that may be a discussion. But that is one of the concerns, and that was a big concern early on. Worrying about the recipients getting infected after the transplant, especially as we're giving them immunosuppression with the transplant to increase their risk. As Camille mentioned, transplant recipients did significantly worse with COVID compared to non-transplant patients, and that was a big concern we had for us. And obviously the challenges was with what the pandemic effect on the healthcare system throughout the country and really the world was significant as well. We had to preserve our PPEs. We had to assure there are beds for the patients who are sick. So all that was a big challenge, and we had to deal with. Now, looking at COVID infection in organ recipient, Camille has mentioned some of these reports, and we We participated in some of them and looked at it, and truly patients with a transplant has significantly worse outcomes, especially if they were sick enough to needing to be hospitalized, and the mortality was reported anywhere between 10 and 30%, which is a lot worse than those who are not immunosuppressed. So that's a big difference that we had to deal with. So the way I think about it is, as we follow the rules, it's just like any rule we follow. Do we go drive under the speed limit because we don't want to get a ticket, or because we don't want to die? And that would be the right answer, is because we don't want to die. And that's where we really are emphasizing that patients need to be prepared for transplant and need to be optimized and decrease their risk. And that's where the recommendations to get vaccinated going into transplant and vaccinated after transplant. So the regulatory oversight really is seeking optimal recipient outcome and best utilization of organ donors. And COVID risk is significant in the immunocompromised patients. And that's why optimization of transplant candidates by decreasing their risk is really routine practice for us, and it will benefit everyone. I will stop here, and I want to leave you with the slide that Camille ended with, because I really think that is something that we all should follow and should think about all the time. And we're glad to take your questions.
Thank you, Dr. Elias. So this was great. I made a few notes of some learning points that I think are important to reinforce, and then we'll try to go through some of the answers, some of the questions that we may need to just dive a little bit deeper on it. I think we learned that we can do a little better in management of COVID-19, but it seems the most effective intervention that we've been able to do so far has been the vaccination. And I think the one point that we want to reinforce is, unfortunately, patients who are on the anti-rejection medications, on immune suppressive drugs, they tend to respond less. That's why we give at least the 3 doses of vaccine. But if patients that are not being transplanted yet, they're on the waiting list, or have just chronic kidney disease or on dialysis, these are the patients that if they get vaccinated prior to transplant, they're able to get a much better immunity than if they get vaccinated post-transplantation. So I think that was really important. I think second that Dr. Cotton mentioned was that there's, for the unvaccinated patients, there's a clear, over like 11-fold higher risk of dying. And I think this has been kind of clearly shown of how much benefit the vaccine has. And with the vaccinated patients, they can still get an infection. And so that's what she was calling the breakthrough cases. So patients that have vaccinated ended up developing an infection. But what's remarkable was that, the graph that she showed, where there was a very flat line in terms of the number of hospitalizations and deaths of patients that were vaccinated. So it seems that the vaccine is giving that protection and preventing patients from getting very sick from the COVID infection, which I think it's really important. And she uses this analogy to the seatbelt, which is great, I think, and I know Dr. Elias put the car crash there, and the vaccine is that seatbelt that people are using. Of course, we can still have an accident, but this seatbelt, it's going to give you that protection. And I think we have clear data now that this is definitely beneficial for our patients, in particular because we're putting them through medications that may increase their risk of infections in the long term. Dr. Cotton, there was a question about side effects of the vaccine that I would like you to just maybe share with us a little bit of why some patients develop, others not, and how should we see how bad are some of these side effects, and now based on all the data we have.
Sure, that's a great question. Well, we have collected more data on these vaccines than anything else we've done in modern medicine, which is amazing. And many of you may have signed up for the vSafe program, which is where you can actually report symptoms or lack of symptoms into the system. And I really appreciate any of you that have contributed to our national understanding. There's also, whenever we see any adverse effects, we report into a different system called VAERS. But we have a tremendous amount of information. And the bottom line is these vaccines are incredibly safe. Incredibly safe. Overall, people get, up to like a quarter to a third of people may get fevers, they may feel lousy, they may have, aches or kind of flu-like symptoms. a tiny percent of people develop major reactions. And what we see is that these vaccines are so much more safe than running the risk of COVID-19. So in general, the vaccines are really well tolerated. And I vaccinated myself. I've strongly recommended it for my husband, who's a critical care attending, and for both of my children who are in their late teens now.
Thank you, Dr. Cotton. There are a few questions about the effect of immune suppression of anti-rejection medications on the vaccine response and also on the infection. I can try to answer some of those. You know, it's complex because we use a combination of anti-rejection medications to prevent a patient from rejecting a kidney transplant. So we know that there are certain medications that may be slightly more powerful than others. And one question of one of our audience from Paul was, you know, should be a reduction in immune suppression be done in patients who receive a vaccine, in particular, you know, specific types of immune suppression such as mycophenolate? And the general answer is no, because, you know, one of the key aspects here is that even though we are in a pandemic and we want to definitely get every patient protected, we also want to make sure that we're giving enough medication to prevent a rejection from the transplanted organ. So every decision that we make, you know, is going to have a risk. And I think this is where, you know, your treating physician is the one that you're going to be discussing with in terms of getting further guidance in your specific combination of immune suppressive drugs that you use, to decide, you know, if there's anything that should be adjusted in the long term. But in general, we are not recommending adjusting immune suppression just before getting a vaccine. But you know, this is in regards to, in particular, trying to preserve as much as possible the kidney transplant outcome and preventing any form of rejection. So Thomas McGill, Dr. Cotton, has a question about, is a third dose and a booster dose the same potency? And I think this is a common question I think all of us have. So maybe you can just highlight again. I know you showed a slide, you know, highlighting that.
Yeah, it's confusing. So for transplant patients, the third mRNA dose is the same as all the other doses, okay? So, and that was recommended as of August, and it's recommended that it be like a month after the second dose or later, but so all transplant patients really should be getting that third dose. And then 6 months later, a booster dose is recommended. The booster doses for Pfizer and J&J are the same as all the others. The booster dose for Moderna is half dose. And that's because it was a little more what we call reactogenic. So people were more likely to have a reaction. So the dose was cut in half. But that's not the additional dose for transplant patients. That's 100 micrograms. This one's 50 for the booster. It's a little confusing when you fill out the paperwork. And I saw some questions about, like, how do I get a vaccine? Like, I just signed up at CVS. You can just Google online. If you go online, you can do, how do I get a booster? And you can go, you know, CVS, Walgreens. And if you fill out those, click the right boxes as you're booking your vaccine, they will give you the right dose. And no harm done. If you get, like, if you accidentally get like the higher dose, you're not going to be hit by lightning. If you inadvertently get a low dose for what should have been your additional dose, like if you get the half dose Moderna, you could just go back and get another one. No harm done. I would like to say that we overall have seen slightly more complications with J&J. So for now, I would tend to favor getting one of the mRNA vaccines. Overall, I think there's a bit more robust safety data, and I think you could go with either of the mRNA vaccines.
And on the same lines, there has been some information in the media about mixing vaccines. So is this something that that people should be worried about, consider? I know it's maybe we don't have enough evidence, but I'd love to hear your thoughts.
Yeah, I know that's a popular question. In fact, I emailed my colleague, Martina Sester, who's in Germany, who's done a lot of work with this. I thought I'd sort of reach out of the country. I know what the American data looks like, but she's done a lot of good data herself. So the question is, especially if somebody's had Moderna, should they get Pfizer? If they've had Moderna, should they go with Moderna, or should they, we'd call it the mix and match. And realistically, she and I discussed it back and forth, and we both agree it's really what we call a coin toss. The data look fine either way. And right now for the booster, it's not clear which one would be better. I will say, so some people view that as a negative and say like, oh, they can't make up their mind. No, the glass is totally full here. Like, it's amazing. These are miracle vaccines. Both are incredibly protective, and both get really high levels of boosted immunity. So it's like a win-win, basically. It's a good coin toss. It's a win-win. I went with whatever I could book. So I'm getting Moderna on Friday, just because that was what was available to me.
Fantastic. Matt has a question, about the holidays. Holidays are coming, Thanksgiving. We want to spend time with family. Our patients want to spend time with family, and it's cold already, so they gotta go indoors. So vaccinated patients can transmit COVID, but much less than unvaccinated patients. What sort of recommendations can we generally give to our patients during this holiday?
So there is still risk, especially because the numbers are still high. And it depends a little on the type of gathering you're having. If there are a lot of small children who are not yet vaccinated, and in school, and if it's a lot of people, it's all about numbers. So if it's a large group, lots of little kids, people crowded, poor ventilation, that's a pretty high risk situation. I'm not doing that type of thing for the holidays this year. I would say if you're concerned, put on a mask. It's amazing how much masking helps. You can also do, last year we had really creative ideas. We had outdoor cocktail parties for Thanksgiving. It's really nice. Then you don't have to have everyone in your house. You can do briefer things. We know that transplant patients are not necessarily as well protected. And so I would still ask that people be cautious, maybe not quite needing to be as cautious as last year, but nonetheless, I would still be cautious, and I'm worried about the holidays.
Thank you. Yeah, I think those are reasonable, and like anything, there are always risks, but I think we're at a point that if everybody on your small kind of bubble that we call now are all vaccinated and are at least wearing masks if they go in public and other things in a closed environments, I think this creates some reassurance or lowers the risk. Thank you so much, Dr. Cotton. There are a few questions still along the lines of, okay, we get vaccinated, we have the cellular immunity, so your immune cells start recognizing the virus, and then you have the antibody immunity, which is the antibody recognize the virus. And I'm an immunologist by training, so I can briefly kind of just give you a background. So there are two major branches, or armamentarian or guns and weapons that our immune system kind of uses to fight infection, and both are super important, both the antibody and the cell mediated immunity, or the defense that comes from immune cells. And the data that we have generated in our cohort from MGH patients that were kind enough to be part of it, and some of the other studies in other centers is telling us that some patients may actually not generate an antibody, but still generate a very strong cellular response. Of course, if you have both, you tend to be more protected, but we don't have good ways of testing this clinically on all our patients. So that's why the additional doses of vaccine to try to enhance as much as possible the immunity, and therefore try to get the most protection. And as Dr. Cotton was mentioning, most important of all is to see what's happening in our community. If the numbers of cases are going higher, we need to be more cautious. We need to be wearing masks and other precautions, I think, to try to prevent having exposure to the virus. So, and I know, it's because we don't have all the answers, this is something that's of course kind of evolving. And let me see what else do we have here as questions that we have not addressed. There's one. Go ahead.
There's a
Dr.
question about air travel.
Mhm.
And, we've always worried about air travel for transplant patients. It's pretty crowded. And we know that there's risk, and especially in the crowded airports around the holiday season. So we would recommend that people not travel if possible. And if you really do need to travel, if a loved one is ill, or if there's really a strong reason, you could wear an N95 on the airplane, but that's pretty uncomfortable. Things to do would be like to eat before you get on the plane, so you don't have to take off your mask to eat or drink the entire time you're on the plane. But I would be very cautious. There's also, within the United States, no mandate that everyone on the plane needs to be vaccinated. So you could be sitting right next to somebody or between two people who are unvaccinated and maybe at risk for transmitting infection, which would probably make, at least that, I'd be pretty nervous about that for myself.
Thank you, Dr. Cotton. I have a question here from Susan about some of the risks, prior to transplant, after transplant, and COVID. So if I get your question right, so overall, patients with any form of chronic diseases can have a higher risk of infections, including COVID. And the vaccine will prevent you from having serious infections. So I think the benefits of transplant, if you are already on dialysis or if you have advanced kidney disease, outweigh any risk that we could talk about COVID in general. Just because unfortunately, as your kidneys fail, you have a lot of toxins and things that accumulate in your body that unfortunately are not very healthy for your heart and your blood vessels. So overall, of course, if you get to the stage that you need a transplant is the best option. And now all the testing that's being done on donors and recipients and the way the hospital had prepared for more than a year or two now of the pandemic, we know how to prevent exposures inside the hospital. So in general, it is a safe place to be. And our patients are definitely kind of protected from that ground.
And that's a very good point, Leo. We went through this in the early days of the pandemic. We had these concerns, and we appreciate hearing questions like this, because this is what we had to live through. And we were worried about living donors who are very healthy, and we didn't want them to get the infection if the hospitals were the place where they would get infection. But we've identified over time that we were able to protect patients. Now we're extremely careful. Our regulations, our rules about how, every time we're rounding on patients, we're all obviously wearing masks all the time, but also the patient themselves are wearing masks when we're rounding on them, when the team is coming into the room. So that's essential. And this is how we protected everybody. And as Camille said, with the vaccine, we pushed that protection, 11 notches, 11 times higher in essence, because the risk became a lot lower.
And Dr. Elias, could you comment as well on what are the testings that are being done in the donors and potential transplant candidates before they come in, so that the audience can better understand, I think, all these safeguards that are being put in place?
Yes, that's so we're testing every donor, we're testing every recipient. In essence, everybody going into the transplant is being tested. The donors, as far as deceased donors, Dr. Cotton mentioned the front of the nose, the anterior nares test versus the nasopharyngeal, which is the back of the nose, and the nasopharyngeal being the gold standard. That's more specific. But deceased donors are even, they're patients who have a breathing tube, and we can actually go down into their bronchus, into their lungs, and get a sample from there. So they're getting a sample from their nose and a sample further deeper into their lungs to be reassured that they're negative going into transplant. As far as living donors, they're tested only with the nasopharyngeal test, and every recipient that comes in gets tested as well on arrival. and Camille and her team, and the infectious disease team working with the lab, we have facilitated expedited testing for transplant patients because we don't have a lot of time and we always wanted them tested, and our lab has been superb in getting us those tests immediately when we bring in a patient, and we get results within a couple hours or less, which most of the time is plenty of time for us when we're calling a patient in for a transplant.
I want to emphasize that's exactly right, Nahel. And I want to emphasize that those are not the rapid tests. They are PCR tests. They are gold standard. They are the best tests out there. But we have asked the laboratory to work with us so that we never slow down transplant. And that's been a huge team effort across the board. Can I ask both of you to comment? How do you feel about the safety of being a patient at Mass General, either in clinic or walking around the hospital or in the hospital during the pandemic? What does that look like to the two of you? Leo, I'll call on you first.
Yeah, I think we've learned so much about COVID in the past 2 years that, right now I feel quite safe in the hospital. I wear my mask. We don't eat, with other people because we know that this could be, unfortunately, still a potential site where infections can propagate. So we miss that. But at this point, until our numbers are higher, I think we just gotta work and be tight and try to protect both ourselves and our patients. So overall, I do feel safe. Dr. Elias?
Absolutely, I second that, and we really got a lot more comfortable over time. I think we learned how to deal with this. That was a big piece of it. And then now we know that everybody is vaccinated around us. We are all vaccinated in the hospital. All of us who are working in the hospitals are required to be vaccinated, and we are vaccinated. And I feel much better because of that, because of wearing the mask, because of the routine that we've gone through. And again, it's I think a big piece of it is also we owe it to our patients to be very responsible and very responsive to us. It's very routine for me to, as I was saying, have the patient put their mask on when we come in the room, and nobody has an issue with it. Everybody's doing it, and it's for the safety of everybody, for our safety, for their safety, and that's how we take care of them.
Thank you. I think there was a question maybe for Dr. Cotton about the mRNA vaccine 101. So what is an mRNA vaccine? And so just for the lay audience with not too complicated terms.
Yeah, it sounds pretty, it's amazing technology, I will say, but it's actually quite simple. It basically is something, so it's this vaccine that gets injected into our bodies, and our cells then make protein, and we then have an immune response to that. It does not go into our DNA. That's not scientific. So it does not go into our chromosomes. It doesn't go into our eggs or sperm. It's not going to be our next generation. That is completely impossible. It does not affect fertility. That's not science. All those things. It's amazing. I mean, there's nothing the vaccines can't do according to the crazy internet, but honestly, it goes away really quickly. And as scientists, the three of us know, mRNA is something that's actually RNA is something that's there very quickly and goes away. It's not something, I think especially Leo working in the laboratory wishes it hung around a little longer so he could get his hands on the RNA, but it goes away quickly. So once it's in the body, so basically it goes in, it harnesses the cells, it's amazing technology, but then it's gone. My mRNA vaccines from January are long gone, but the effect on my immune system is there. It's robust, it's durable. You saw that chart where I showed you that even though there are about 1% of vaccinated people are having breakthrough infections, the vast majority of people are not, who have breakthrough, are not hospitalized and not dying. So it really does work. It's amazing technology. We're going to be using those vaccines for a lot more things. In fact, this is very exciting. they're making a CMV vaccine. So for those of you that know about CMV, which is the most common infection after transplant, Moderna is starting a phase 3 trial in healthy people, not transplant patients yet, because that's how we do it in science. And it's possible that we might be able to vaccinate ourselves out of CMV someday, which would be wonderful for those of you that know what CMV is and all of that. And I'm sure both Dr. Elias and Dr. Riella would be thrilled to not have CMV anymore. Wouldn't that be amazing? I also want to mention, really important, everybody on this call should have a flu shot. Don't forget your flu shot. I was just on an influenza call today with the CDC. We are seeing a lot more influenza this year. And so please, 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 everybody get your flu shots. The worst thing I see is a transplant patient who didn't have a flu shot who comes in with devastating influenza. Please don't do that. There's no reason not to get a flu shot. Or in other words, there's every reason to get a flu shot. I got mine. I suspect the two of you got yours. Yep.
Yes.
In France, they're actually giving them with the booster for COVID-19, they're giving a flu shot the same day. So you can do that. You can separate them. All good.
Thank you. Thank you, Dr. Cotton. I think we're getting up to the hour. I think it was a very instructive session. I think I've learned a lot as usual from Dr. Cotton, and of course, you know, we as we get more information, as we learn more, we're going to keep sharing with all of you. And Stacy may have some instructions about the availability of the video and some of the questions that we were able to answer, so that people can further check and maybe watch any specific session, part of what we discussed today. Stacy?
Yes, so I did record the session. I'll be able to post it and share it with anyone who either missed it or wants to watch it again.
Thank you. I'd like to thank Dr. Cotton for the amazing work that she does for our patients, for our hospital, and for the nation, because I think, you know, she was really kind of leading the efforts for us to learn how to best treat our immune suppressed patients, and how can we get ahead of the curve. Dr. Elias also, you know, is an amazing surgeon, and he really cares about, you know, the quality of the program, the safety of the program, and he's an amazing partner to be sharing and working with side by side. And Stacy, who is a new team member, but she's our program manager, and she is being incredible. And we hope to, you know, keep doing these webinars and keep providing information that may be useful for you, patient, family members, and we're really excited, I think, to be using Zoom in a productive way to better connect with our patients, despite, you know, some of the Zoom fatigue that I think we are living on. But thank you so much again, Dr. Cotton, Dr. Elias, and maybe if you have any other final comments, please.
I seconded what you said, Leo, and thank Camille and Stacy for all the work, and everybody who attended, and thank you again.
Yeah, thanks to everybody. We've been a really good village during the pandemic, and we've worked really, really closely together. So we appreciate everyone's efforts. Thanks to both Nahel and Leo, and then Stacy for organizing us, because it's hard to organize doctors. So we appreciate that. Thanks, everybody. Stay safe out there.
Bye, everyone.